Hello, good evening, everyone. Can people hear me? Okay. Oh, fab. Thank you for responding. We'll just wait for a few more minutes to let more people join in and make a start then. Thank you. Good evening, Joanna. Also, can people see the slides okay? If you could just pop in a thumbs up in the chat, that would be very helpful. Thank you. Thank you. Okay, fine. So I think we'll make a start and people can join in as we go along. So, good evening, everyone. Thank you for coming in. I am Niharika. I'm one of the Foundation Year 1 doctors currently in East Midlands. And this is our first teaching on respiratory as a part of our final year teaching series with Mind the Bleep. So today's topic is understanding chronic airway diseases. So the topics we'll be covering would be asthma, COPD, and bronchiectasis. Again, these are quite high yield conditions for your finals and very common in the population as well. So we'll be going over the clinical features, your signs and symptoms, what are the common investigations that you can order for these patients, and how to go about making a confident diagnosis, as well as managing a stable and an acute exacerbation of these conditions. Can people put in the chat if they could see the next slide so I can just see whether my slides are moving or not? Thank you. Fine. So we'll make a start with a case. So we've got a 17-year-old boy who's presented with a history of wheezing and a nocturnal cough. He also had eczema in childhood, and a spirometry is showing that the FEV1 is 70% of predicted. The FEV1 FVC ratio is 0.65, so an obstructive sign. And after administering bronchodilator, the FEV1 has increased to 85%, and which is the most likely diagnosis. So I'll just put a poll in the chat now. So we've got 8 responses. So far, a few more. Just going to give you a few more seconds. And if people are feeling brave, do give in your reasoning as well in the chat. That would be quite helpful. Okay, last 10 seconds. Fine. Okay, so we'll stop there. So 86% have said asthma, 13% for COPD. So asthma is the right diagnosis. Very good. So some of the clues in this question were wheezing, nocturnal cough, and eczema in childhood. So that is a risk factor for asthma as well. We've got an obstructive picture on spirometry, but that doesn't really help us choose between these conditions. The main clue here would be the improvement of FEV1 after administering a bronchodilator, essentially. So again, I've got lots of nice options in the chat: atopy, nocturnal cough, age, yes. So with COPD, you would expect a later age of onset. The FEV1 FVC ratio would still be valid for COPD with the wheeze. However, the FEV1 improving with a bronchodilator, I wouldn't expect this marked improvement with COPD. Right, okay, so what is asthma? So it's a chronic inflammatory disease of the airways, and essentially something triggers the immune system to overreact. Sorry, not the immune system, something triggers the airways to overreact. And essentially you've got increased inflammation in the airways, so they get quite swollen up. Constriction of the smooth muscles around the airway, as well as lots of mucus secretion. So if you look at the slide here, the picture here on top, on the right side, we've got quite a narrow lung lining. So that causes your obstruction and lots of mucus and coughing, etc. Again, with asthma, it's usually reversible. However, it's very important to get the management right from the start, because it can lead to persistent symptoms if not managed properly. So in terms of your history, your common symptoms would be wheeze, particularly during expiration, shortness of breath, cough, particularly worse at night. Patients can have chest tightness. So in an OSCE, or when you're exploring these symptoms, you can start with an open question and then check for your risk factors. So these are usually episodic, so the patients can be completely symptom-free between exacerbations. And again, diurnal, meaning the symptoms are worse at night or early mornings. Try and explore some time with what are the triggers that worsen symptoms. So it can vary from patient to patient. Sometimes it can be due to hay fever, so pollen during the summer season, pets, sometimes with exercises, dust, you've got lots of symptoms. In terms of your risk factors, so there are associations with a personal or family history of atopy. So when I say atopy, I mean conditions like atopic eczema, dermatitis, allergic rhinitis, and also patients, if they've got lots of respiratory infections during infancy or childhood, they tend to have an increased incidence of asthma. So that's, again, something worth exploring. A lot of these patients have worsening symptoms after the use of beta blockers, particularly the non-selective ones like propranolol and NSAIDs, as well as aspirin. So these medications can cause bronchospasm, so generally avoided with asthmatic patients. So that might be a question in your AKT, that patients come in with asthma. Which medication would you want to avoid with these patients? Because it's a chronic condition, again, it's very important to explore how these symptoms are affecting their quality of life, especially with school-going children. It can sometimes be restrictive in terms of their activities. So we want to explore and address those things as well. In terms of making a diagnosis, so this is based on the new guidance, which was released last year, November. So it's in collaboration with NICE, BTS, and SIGN. And essentially what they say is, do not confirm a diagnosis of asthma without a clinical history and a supporting objective test. So you need a strong suggestive history as well as a test to support that. And we'll get to what those are in the next slide. The only exception to this would be if children are aged under 5. So if you're suspecting asthma, however, it's very challenging to diagnose it for these patients. So you can treat them with ICS and then review on a regular basis. And once they're above the age of 5, we can perform those objective tests to confirm the diagnosis. So in terms of what those tests are, so again, the new guidance has provided us with an order of these tests. So this is a bit of a detailed slide, and I'll go over it briefly. Let me know if you've got any questions with this, okay? So say, for instance, you're in a GP surgery and a patient's presented with symptoms suggestive of asthma. You can start with checking the blood eosinophil count, or FeNO in the first instance. So blood eosinophil count would just be a simple FBC, and if the levels are above the lab range, that with the history itself would be positive for asthma, so you can confidently make the diagnosis. If you are in a GP service or facility where FeNO is accessible, you can try that. So FeNO is fractionated concentration of nitric oxide that's being exhaled. So nitric oxide is high in areas of inflammation. So if you look at the image on the top right here, you can see someone blowing into a device, and that essentially measures the concentration of nitric oxide being exhaled. So for patients 16 or over, if it's above 50 parts per billion, that with the history can confirm the diagnosis of asthma. Now, if either of these tests are negative or inconclusive, and you've still got the suggestive history, you can move on to testing for bronchodilator reversibility with spirometry. So you would do a normal spirometry, and usually with asthma, it would show an airway obstruction. So your FEV1, FVC might be less than 0.7. And you can give them a bronchodilator, say salbutamol, and retest them, and the FEV1 should improve. So if it improves for about more than 12%, then that is a positive finding as well. If for some reason the reversibility testing is delayed or not available, you can provide patients with a peak flow meter, counsel them on how to use it, and measure peak expiratory flow. Essentially, they can do it a few times a day for about 2 to 4 weeks. And if there is a variability of more than 20%, again, that is positive for asthma with the history. If all of these tests are negative and you've still got a suggestive history, then you can refer patients to specialist settings for bronchial challenge tests. So that's the sequence of testing. If you're suspecting patients to have occupational asthma, so some of the clues in your history could be an adult onset of asthma, or patients who had asthma when they were children, but it's been dormant since, and now they're suddenly getting these symptoms. Some of the other clues in your SVAs might be that patients have got these symptoms while they were here, but when they went for a holiday a few weeks ago, they were completely asymptomatic, and now the symptoms have come back. So those features should prompt you towards suspected occupational asthma, and they require a specialist referral for further assessment. Right, okay, so this is the diagnosis bit done. Does anyone have any questions about it? I understand it was a bit of a chunky slide. Fine, okay, so I'll move on to the next slide, but if you do have questions, do pop them in the chat, okay? So now when we go to managing asthma, so the aim is to get complete control of the disease. So anything less than that is suboptimal. So that means no daytime symptoms, not having to wake up at night because of these symptoms, not having exacerbations, not having any functional impairment due to asthma. So some of the things to explore when managing asthma would be adherence. So whether patients are appropriately counseled on when to take the relievers and when to take the preventers. Are they taking it regularly? checking the inhaler technique, checking for smoking, active as well as passive. Particularly these days, it's quite common with vaping and e-cigarettes as well. So those are the things that you want to explore. Again, occupational exposures, seasonal factors, and we want to exclude any other diagnosis as well. In terms of your pharmacological guidance, so again, this is with the new NICE BTS and SIGN. So for any patient who's newly being diagnosed with asthma, we've moved on to giving them air therapy. So that is an anti-inflammatory reliever therapy. So that's a single inhaler that contains a low dose inhaled corticosteroid with formoterol. And formoterol is essentially a LABA, but it's got a very rapid onset of action. So you can use it as a reliever as well. So this is your reliever inhaler essentially, and patients can use it as and when needed if they don't have symptoms very often. So say, for instance, if it's less than 3 times per week that they have got symptoms, we can start at this step. If they are severely symptomatic or they've had exacerbations in the past that's been severe, you can start at a low dose MART, which is a maintenance and a reliever therapy. So again, this contains an ICS and a LABA. Again, that LABA is usually formoterol. And patients can use it regularly. So depending on the brand, it can be once a day, twice a day. And it can also be used as a preventer if they get symptoms. So this is very good because it's only one inhaler. So there's hopefully better compliance with it. If the patients are symptomatic, despite being on the low dose MART, we can move on to a moderate dose MART, which contains a bit of a higher dosage of the steroid. And following that, if they are still symptomatic, we can check their FeNO levels and blood eosinophil counts again. And if either of them are raised, they should ideally be referred to specialists for further management. If they're not raised, you can try a leukotriene receptor antagonist like montelukast or a LAMA with the MART and assess them from there. So essentially, with asthma management, we're looking for 2 things. We're looking to open up the airway and reduce the inflammation. This is the treatment summary from the NICE BTS and SIGN. So it's about 40 pages of recommendations summarized into one slide. So if you look at the right here, this is for patients who are on the new pathway, which we just discussed now. And on the left, we've got patients on the existing pathway, and they've provided steps where you can consider moving on to the new pathway. So if you see on the left here, they've said that the patients who are on SABA only should ideally be offered the low dose ICS with formoterol. And if patients are on the other existing pathway, you can consider switching them to the new therapy. Right, okay, so that's asthma done from a chronic disease point of view. Let's move on to case number 2. So we've got a 50-year-old man who presents with poorly controlled asthma to the ED with severe breathlessness and wheezing. His oxygen saturation is 94% on room air, his respirate is 28 breaths per minute, and he's using his accessory muscles to breathe. He's also unable to complete sentences. Which of the following is the next best step in managing this patient? So again, I'll put up a poll now. Okay, we've got about 16 responses so far. I'm going to wait until 20. Fine. Okay, so we'll stop there. So the majority have gone for C, which is nebulized salbutamol and oral corticosteroids. We've got some who've gone for LABA, ICS, and ABG. Okay, so the correct answer is administering nebulized salbutamol and oral corticosteroids. The other options are potentially correct for long-term management, but I'll explain why we've gone for C here. So this patient essentially is having an acute exacerbation of asthma. So our clues here would be that he's in the emergency department, he's got severe breathlessness, he's got quite a high rest rate, he's using his accessory muscles, and he's not able to complete his sentences. So starting a LABA or increasing the dose of his inhaled corticosteroids or adding an LTRA are potentially good options to consider for future long-term management. However, the question here asked for the next best step. So again, be wary of these terminologies in your exams, like next best step, what is the most definitive management, or what is the most definitive investigation to confirm diagnoses, words like that. You could perform an ABG and that might be helpful. However, it's not, he's saturating about 94%, so it's not currently indicated. If he does get worse, that is an option for later then. So in terms of an acute exacerbation of asthma, it's very important to assess the severity because that would guide your management. So there are two ways for doing it. One is through measuring your peak flow readings. So say, for instance, someone comes to ED with asthma. If you're able to get that reading, well and good. However, a lot of these patients can be acutely unwell, so it wouldn't be possible to do this. So then we can rely on our clinical judgment. So you've got moderate, severe, and life-threatening. So a moderate asthma might be a person who's slightly short of breath, but he doesn't have any severe features. He's clinically stable. For your severe, you can have a person who appears quite distressed from the end of the bed. So they are not able to complete their sentences. They've got a high heart rate. They've got a high rest rate. For your life-threatening asthma, on the other hand, so this is a sign that patients are getting exhausted, and you can see signs of exhaustion. You can sometimes have a silent chest, and that means that the air is not traveling very well through the airways. They can have poor respiratory effort, hypotension, low oxygen saturations. So if you do identify any of these patients, we need to escalate it to seniors quite urgently because they are at a very high risk of going into respiratory arrest and they likely need intubation. There's also something called neofatal asthma, and that is if the PaCO2 is raised in an ABG or if the patients are requiring manual ventilation. So that is again something to remember. And also, these slides would be provided to you after the lecture, so you can have a read as well in your own time. So in terms of managing an acute exacerbation, so depending on the severity, escalate it to seniors or get ITU input quite early on. You would also be expected to assess and see patients who need to be admitted or whether they can be managed in the community. So as a general rule, all cases of life-threatening asthma should be admitted. All cases of moderate or severe, if they're not managing with the initial bronchodilators, they should also be admitted. Some of the other features that you should consider for an admission would be psychosocial factors. Say, for instance, you've got an old person who lives alone and you're not confident that they'll be able to look after themselves. So we can consider admission for those patients as well and err on the side of caution. aiming for oxygen saturations between 94 to 98%. And in terms of your pharmacological, so again, we are doing two things. We want to open up the airway and control the inflammation. So to open up the airway, we use our bronchodilators. So you can use salbutamol via NEBs. So the usual dose is between 2.5 milligrams to 5 milligrams. And salbutamol can be used as a back-to-back NEB, so you can give it every 15 to 30 minutes when required. Ipratropium bromide is another bronchodilator, but this can only be given every 4 to 6 hours. So the dose again here is 250 to 500 micrograms, maximum 4 times a day. You can give patients a course of oral steroids to control the inflammation. Usually we give it for 5 days. And if they still have, and if the oral route is not available, you can use IV hydrocortisone, methylprednisolone as well. You can also use IV magnesium if the patients have not responded to this therapy. However, this would be done after discussion with seniors. If the patients are not responding to medical management, then they definitely need ITU for mechanical ventilation. Right, okay, so that's asthma done. We'll move on to COPD now. So COPD is essentially an umbrella term for multiple airway conditions that cause difficulty breathing. So it's not fully reversible and it is progressive in nature. Just briefly on the pathophysiology. So essentially, it is caused due to long-term inflammation, commonly due to inhaling particles like tobacco smoke. And it can manifest in multiple ways. So you can have chronic bronchitis, which is when airways become thicker from fibrosis and you get lots of mucus production. And you can also have emphysema, and that's when the walls of the alveoli break down. Now, alveoli are important for exchanging gases. So essentially, the breakdown of the alveoli reduces that gaseous exchange, and you can have low CO2 and high carbon dioxide because of that. So in terms of whom to consider a diagnosis in, so if patients are aged 13 or over, if they've got a smoking history, and that includes being an ex-smoker, or if they've got any of these symptoms like exertional breathlessness, chronic cough, regular sputum production, frequent winter chest infections, and a wheeze as well. So in terms of your diagnosis, you can make a diagnosis with a clinical history, which is often supported by spirometry. So spirometry is the gold standard to support the diagnosis. And again, you would have an obstructive picture. So the FEV1 FVC ratio would be less than 0.7. However, unlike asthma, there would be minimal or no response to your reversibility testing. So your FEV1, you wouldn't expect a massive improvement with administering a bronchodilator. NICE also suggests that at the time of making your initial diagnosis, consider performing a chest X-ray to exclude any obvious cancers, and do an FBC as well to exclude anemia to be causing these symptoms, because anemia can cause breathlessness as well. In terms of your chest X-ray findings in COPD, so they're non-specific, but usually you can have bullae, which are essentially air trappings, and you can have hyperinflation. So the trapped air essentially takes up space. So the lungs expand to let more air in, and over time you can have a hyperexpanded lung. If you look at the chest X-ray here, the diaphragm looks quite flattened, and we can see the inferior border of the heart as well. So that indicates a hyperexpanded chest. For your in terms of your full blood count, you can have polycythemia. So that's a high hemoglobin count, and it suggests that we've got low levels of oxygen in the blood. There are also lots of other investigations that can be considered. So if you're suspecting bronchiectasis, you can perform a high-resolution CT scan of the chest. You can do a sputum culture, especially in exacerbations. And the most common organism grown is Haemophilus influenza. COPD over time can also lead to right-sided heart failure. So that's cor pulmonale. So some of the signs that would indicate that would be a raised JVP and pedal edema. So if you're suspecting cor pulmonale, you can consider doing an echo, doing ECG, BNPs. If there's uncertainty between asthma or COPD, you can also measure peak flow readings. And you can also check for alpha-1 antitrypsin deficiency. So this is a rarer cause for COPD. It's a genetic, it's passed down through genes. However, so some of the clues in your history that would indicate for alpha-1 antitrypsin deficiency to be the cause of COPD would be a younger age of onset, or they've got no smoking history, or they've had parents who also had COPD. In terms of management, so non-pharmacological ones would include smoking cessation advice. This is the single most useful, helpful intervention for these patients. So again, offering smoking cessation advice, offering nicotine replacement therapies to these patients are important. Also, vaccinations for influenza and pneumococcal to prevent chest infections, and pulmonary rehab to get exercises and also to help improve the flow of air through the lungs. So anyone who views themselves as functionally disabled by COPD can opt for pulmonary rehab. In terms of your pharmacological management, so again, we go for bronchodilators. You can go for either a SABA or a SAMA, as and when needed. However, if the patients are still symptomatic, despite that, you can move to a combination of 2 inhalers. Now, you've got the choice of a LABA with an ICS or a LABA and a LAMA, and it depends on whether the patients have got asthmatic features or not. So if patients have got a previous history of atopy or asthma, if they've got peak flow variability, if they've got high eosinophil counts, then you can consider to treat them with a LABA with an ICS. If they've not got any of those features, we can go for a LABA and a LAMA. If patients are symptomatic despite these, then we can try triple therapy. So that's a LABA, LAMA with an ICS. So hopefully the inhalers help with symptoms. However, lots of patients are still symptomatic despite those inhalers. So there are lots of other treatments that we can consider, usually in secondary care. So we can consider long-term antibiotics for patients who continue to have exacerbations despite being on optimal medical therapy. Usually it's azithromycin, and we need to check for the LFTs and ECGs before we start. ECGs because macrolide antibiotics increase the QT interval, and we want to exclude long QT before we prescribe these. If there's diagnostic uncertainty, you can also do sputum cultures and CT scan, and that will help exclude pulmonary fibrosis or bronchiectasis. You can also treat them with mucolytic therapy like carbocysteine to break down mucus. Other medications like oral theophylline, oral corticosteroids, and oral phosphodiesterase 4 inhibitors are again medications that can be considered, but usually in secondary care. If patients have had exacerbations in the past year, you can offer them rescue medications. So that's a pack containing oral steroids with antibiotics. However, patients still need to be counseled on seeking medical advice when they get these symptoms. Right, okay, so we can go on to case number 3. So we've got a 74-year-old man who presents with COPD, showing signs of cor pulmonale, including bilateral pedal edema and raised JVP. His FEV1 is 40% and PO2 was 7.5 kPa on room air during his last hospital admission 4 weeks ago. Which intervention is most likely to improve his survival? So lung transplant, oral steroids, long-term antibiotics, long-term oxygen therapy, or oral theophylline? And I'll pop in the poll in the chat. Okay, we've got 13 responses so far. I'm just going to wait until we hit 15, if that's okay. Fine. Okay. So the majority have gone for L-TOT. We've got some people who've gone for lung transplant, and we've got some oral steroids and long-term antibiotics and theophylline. So the correct answer is long-term oxygen therapy. So essentially, this patient has severe COPD causing heart failure. So he's got an FEV1 of 40%. So that's a sign of severe airflow obstruction. And he's also hypoxemic on his blood gas. Essentially, this is just one of the things where, whether you know it or not, long-term oxygen therapy has survival benefits. Steroids or long-term antibiotics or oral theophylline are more of a symptom control or things to prevent exacerbations. However, they don't have proven survival benefits for patients in the long term. Lung transplant is a good choice. However, given the patient's age and comorbidities, it would be unlikely an option in this scenario. So, long term oxygen therapy is very helpful, especially for clinically stable non smokers. So, non smokers is very important, and that is because oxygen therapy is a safety risk for fire at homes. So, if you've got patients who are eligible for LTOD and if they smoke, it's important to refer them for smoking cessation. So, in terms of assessment, so we do arterial blood gases on two occasions, at least 3 weeks apart, for patients who are on optimal medical management. So, if patients have got PO2 less than 7.3, they are eligible. If they've got it between 7.3 and 8, but they've got some of the other complications like secondary polycythemia, peripheral edema, or pulmonary hypertension, then we can offer it to them as well. So, in terms of an acute COPD exacerbation, so usually you would have your normal COPD symptoms, but they flare up or worsen. So, usually triggered by viral or bacterial infections, and the warning signs would be increased cough, worsening shortness of breath, increased sputum production, change in sputum color as well, and that can indicate a bacterial infection. You can have wheeze, chest tightness. So, if any patient presents with any of these signs, and say you're an ED and they've got a previous diagnosis of COPD, it's highly likely that it's COPD exacerbation. However, it's still important to do your A2E and exclude any of the other conditions that can cause it. So, for instance, pneumonia, pneumothorax, MI, PE, these conditions can present with similar symptoms. So, you still need that complete, thorough history and clinical assessment to exclude these other causes. In terms of your investigations, an ABG is very helpful, especially to see how severe the exacerbation is and to help guide oxygen therapy. You can do a chest x-ray, and that should hopefully exclude pneumonia and pneumothorax. You can do a fluid blood count to check for infections. You can do an ECG to check for MI. If patients are spiking temperatures, you can do blood cultures, you can do sputum cultures as well. So that's just something to be aware of. So managing COPD, so again, oxygen therapy. So many COPD patients are retainers, however, not all of them retain carbon dioxide. So the ones that do, we need to target oxygen between 88 to 92%. And we use Venturi masks to do that because they are designed to deliver a specific percentage of oxygen. In terms of your pharmacological management, again, bronchodilators, so really opening up the airway. You can use a SABA and or a SAMA, depending on how severe things are. You can use nebulized or inhaled. You can also give patients a course of oral steroids, usually prednisolone, 30 milligrams for 5 days. In practice, I've seen antibiotics being quite commonly prescribed for COPD exacerbations. However, nice advice to give antibiotics only if the sputum is purulent or the clinical signs of pneumonia. So if you look at the chest x-ray here, we've got a flattened diaphragm and bully, so that indicates that the patient has got COPD, but they've also got a consolidation on the right lower base here. So that is a clinical proof of pneumonia, and we can definitely give antibiotics here. If despite medical therapy, the patients are not improving, you can consider non-invasive ventilation. So some of the signs would be, that would indicate that could be worsening respiratory acidosis, persistently hypoxemic, or severely breathless as well. Do bear in mind the ceilings of care for these patients, as well as the escalation plan before initiating these things. Right, okay, so this is the last case for the day. So we've got a 55-year-old female who presents with a chronic cough, sputum production, and shortness of breath. She has a history of frequent respiratory infections, and her sputum culture is positive for Pseudomonas aeruginosa. A chest x-ray shows signs of bronchial dilation, and which of the following is the most appropriate next step in the management of this patient? And I'll put up the poll now. Okay, so this is a bit of a mixed bag. So we've got 60% people going for refer for a HRCT scan of the chest, and some have gone for starting long-term antibiotics. Okay, fine. So the correct answer is referring patients for a CT scan to confirm the diagnosis. So there are lots of clues again in this question that point towards bronchiectasis. So we've got a chronic cough, sputum production. But that could be common with COPD as well. They've got frequent respiratory infections, fair enough. But they've got Pseudomonas aeruginosa in the sputum culture. Now that is more common with bronchiectasis compared to COPD. And we've also done a chest x-ray that shows bronchial dilation. So that is more indicative of bronchiectasis again. Starting long-term macrolide antibiotics would be a good option potentially in the future if they've got uncontrolled disease. However, we would need to confirm a diagnosis before we do that. And we wouldn't be initiating ICS and LABA because this is not asthma. Again, this is not COPD either. So hopefully that's clear. So, what is bronchiectasis? So, it is a condition where bronchi, which are the airways, get permanently widened due to irreversible damage to bronchial walls. And this damage can be caused by repeated infections or repeated inflammation, essentially. So, this widening in the airways causes mucus or sputum to collect, and that's the perfect breeding ground for bacteria and other organisms to grow, which leads to persistent, recurrent infections, chronic coughing, and lots of mucus production. In terms of its causes, so about 40% are idiopathic, so we don't really know what's exactly causing it. However, there are lots of other causes. So it can be after infections, if there is an obstruction in the airway, say for instance, a foreign body aspiration or an airway tumor, that can impair the clearance of sputum as well. If you've got mucociliary dysfunction, as with cystic fibrosis, alpha-1 antitrypsin deficiency, systemic inflammatory diseases. So lots of causes for bronchiectasis. However, a good proportion of them are idiopathic, just to be aware of. So in terms of your investigations, a high-res CT scan is the gold standard for establishing diagnosis. And we classically see something called a signet ring sign. So if you look at the image here, we can see lots of rings, ring-like looking structures here. And that's essentially the ring bit is your dilated airway, and the gemstone or the seal bit is your pulmonary artery with that bronchi. So usually they should be of a similar size. However, due to dilatation, it appears like a ring. In terms of your other investigations, you can do a sputum culture, and again, that commonly grows Haemophilus influenza or Pseudomonas aeruginosa. Initially, if you've done a chest X-ray, you can have signs of airway dilatation, and some of the buzzwords in your exams could be, you see tram track opacities or ring shadows. A spirometry can be used to assess for airflow obstruction. So commonly, these conditions can cause an obstructive picture on spirometry. And once the diagnosis is confirmed, we can do further investigations to try and determine the underlying cause. So if I go back to the previous slide, so say for instance, I'm suspecting rheumatoid arthritis to be the cause, we can test for rheumatoid factor or anti-CCP antibodies. If patients, for instance, if you're suspecting cystic fibrosis to be the cause, we can do sweat tests. But that is usually done after we've got a confirmation of diagnosis. So in terms of your management, if there is an underlying cause, treat it. Again, vaccinations for influenza and pneumococcal to prevent those chest infections. And the main aim with managing it is to get the mucus out of. So we can trial airway clearance techniques with the help of respiratory physiotherapists. So these are exercises that help clearing up the airway. You can also try pulmonary rehab. We can try mucoactive treatment, so medications to help clear the sputum, things like saline nebs. And again, treating any exacerbations promptly with antibiotics is very important. And if patients have recurrent exacerbations, we can consider long-term antibiotics. We can further consider lung resection or lung transplant for patients. However, they are quite uncommon in practice. So in terms of your acute exacerbation, you would have worsening of the usual symptoms. So worsening shortness of breath, increased frequency or purulence of the cough. Investigation-wise, sputum culture is the most important one because that should guide antibiotic treatment. You can imagine these patients have got lots of exacerbations and they get treatment very frequently with antibiotics. So they're at a very high risk of getting antibiotic resistance. So again, sputum culture is very important. You can do a chest X-ray to exclude any other pathologies. And treatment-wise, antibiotics, 7 to 14 days commonly, guided by susceptibilities if possible. And again, encouraging patients to practice those airway clearance techniques, those saline nebs, and physiotherapy. Right, so that concludes the session. Thank you for attending. Do people have any questions? You can pop them in the chat. Hopefully, it's been helpful. We've also uploaded the feedback form in the chat, so if you could fill that, that would be very helpful. If there's anything you liked, if there's anything you wanted us to improve on, any suggestions. Okay, so where can we access the slides from? The slides would be uploaded if you click on the Medal link. Hopefully, the slides should be there. Thank you. Thank you. So our next session would be on common respiratory infections on the 6th of Feb. So hopefully we see you there. And I'll wait here for a few minutes to see if anyone's got any questions. Fabulous. Thank you, everyone. Hopefully that was helpful. Okay, I'm going to end the session now. Thank you.